Hi, everyone. I'm Megan,
I'm Stacy.
and welcome back. So we'll be doing the Q&A portion for Dr. Held's lecture, which was on pacemaker basics. And thank you for sending in your questions, and Dr. Held has graciously answered them. Thank you very much, Dr. Held. So Stacy and I will be reading them as well as her answers to you all. So let's get started. All right, so the first question that came in is, could you talk about troubleshooting TVPs when Telemonitor shows lack of capture? How would you go about adjusting the TVP, which is the transvenous pacer, and what do you look for? And Dr. Held replied, most commonly, lack of capture with TVP indicates that the tip of the device has moved and requires repositioning. Very rarely would this represent a true increase in capture threshold unless the device has been in place for many days. Regardless, I always start by increasing device output and assessing for improvement in capture consistency. If capture remains inconsistent, I usually proceed with adjusting the TVP position. In general, I start by making small adjustments, either clocking or counting the catheter, to see whether this fixes the problem. If this does not work, I put back the device several centimeters with the balloon down, then inflate the balloon and re-advance again along the new track in the RV to get a new stable position.
Okay. The second question is, excluding AFib, can you differentiate the type of supraventricular tachycardia a patient has on a pacemaker? So can you distinguish if a patient has, for example, atrial tachycardia versus an AVNRT versus an AVRT, et cetera? So Dr. Held said, using a dual chamber device, you can usually get a general idea of what type of an SVT a patient has by looking at the relationship between the A's and V's. If there are multiple regularly timed A's for every V, then this is usually flutter. If the A's and V's line up simultaneously, then this is suggestive of typical AVNRT. If a single A precedes each V, then more likely it is ATAC or AVRT. Further differentiating between these two can be challenging, but there can be clues based on initiation, termination, and stability.
Fantastic. Moving on to the third question. How do you decide the specific VT zones to set? So Dr. Held answered, if it's a secondary prevention device, the slowest zone should be 10 beats per minute less than the rate of the clinical VT. If it's a primary prevention device, 2 zones are generally sufficient, and nominal settings depend on the device manufacturer, but often VT greater than 188 beats per minute and VFib of greater than 220 or 240 beats per minute.
Great. Next question. Can I tell that the lead is fractured on an interrogation? The answer, an abrupt rise in impedance is suggestive of lead fracture, but it's not diagnostic.
Moving on to the next question. What do I do if the ICD is giving multiple frequent shocks for a rhythm that is not ventricular tachycardia or VFib? And she answered, if you interrogate a device and suspect that the device is shocking the patient inappropriately, the primary goal overnight should be to treat the arrhythmia causing the issue, such as increasing rate control medications. The device can be reprogrammed to increase the slowest VT zone or turn off shocks for that zone as well. There are other setting changes that can be made to improve SVT/VT discrimination that are beyond the scope of this talk.
And here's the final question. Should I change anything in the middle of the night if the device is oversensing or undersensing? The answer, this would be a very unusual situation because devices in general, they have an auto-sensitivity feature, meaning they adjust their sensitivity based on measured R or P waves. Oversensing or undersensing can, however, occur in rare situations, generally related to some sort of lead malfunction. Unless that patient is having significant clinical consequence from it, for example, frequent inhibition of pacing in a pacemaker-dependent patient for which I might actually consider a TVP, I wouldn't make any programming changes overnight. Well, that concludes our Q&A session. Thank you guys for tuning in. We'll see you guys soon again.